right? Well, I received few emails, and in that there was some confusion about anatomy. There was some confusion about, say, ductus arteriosus. So what I've done is, in fact, this would be a combination of anatomy and physiology. So we'll be having a very clean idea about where exactly is this ductus arteriosus, or where exactly are those valves. Why it is like we are showing the aorta over here while this left ventricle is over here. Right? All those things will be clarified, because there is a difference between one figure which we are drawing for our understanding. There is another reality, how the heart is actually arranged. So we'll be having a very clean idea about it. That's why this chapter would be like a bridge between anatomy and physiology. Actually speaking, we'll be completing the entire anatomy of heart. But in that, we'll merge the physiology also. Because from next time onwards, we'll be straight away starting with the ECG. Right, so we start within just 2 minutes. Email address. Okay. Yeah, notes are there only. See, there would be a new folder that is cardiology. And in that cardiology, I'm putting all the files. Okay, so it's time. Let's start. Sure. So here it is. Just slightly unzoomed. That's the first rib. This one is the second rib, the third rib, the fourth rib. That's how the ribs are calculated. And the space which is in between, that is called as the intercostal space. Right. So when we talk about, say, this, these are the costal cartilage. So actually the ribs are only up to this point. These are the anterior end of the ribs. These are the anterior end. Then rest of this area, right? That is all cartilage. So that's how things go. Now, heart is situated. You'll find that as such, heart is situated in the center. This is important from the aspect that when we'll be learning about the ECG, only the left ventricle that is projected slightly towards the left hand side. Right? As such, heart is in center, and that's the reason that when we'll be using the right arm, left arm, and the left leg, and that's how the triangle is made, which is called as the Einthoven's triangle, which will be measuring all the electrical activities in these three planes. So from the electrical aspect, right, the right arm is taken, left arm is taken, because heart is considered as a center one, right? So that's how things are there. Yes, when we'll be dealing with the left ventricle, right, when we'll be dealing with the left ventricle will be having more number of muscles. That is, more muscles. The amount will be more, because the quantity is more. That's why there will be more current, and that's why the waves which we'll be getting, the signals which we'll be receiving, they will be much more powerful. So this was our, that's how our heart is associated. See this one. Over here, this we are watching from the right hand side, right? So this is the right view, right side. From right side, the main thing to be seen is this. This one is right atrium. And as we know, in right atrium, there goes the inferior vena cava, and from the top goes the superior vena cava. Right? So this one is the right atrium, and here it is, this small piece, this much, this is the inferior vena cava. Because what really happens is that immediately over here, here is the diaphragm. So inferior vena cava just emerges from the diaphragm and then it goes into the right atrium. However, in case of superior vena cava, right, we have got a wonderful superior vena cava which is coming from the top. So that's how they really enter into the right atrium. All these small things what you are watching, right? It is, now this is absolutely posterior. If it is posterior, then this chamber must be left atrium. In left atrium, there goes the pulmonary veins, right? And because this is right side, so that's why these are the pulmonary veins, this and this. These are the pulmonary veins which are from the right lung. So that's why they are right pulmonary veins. On the opposite side, there would be left pulmonary veins, right? Very fine. Heart is covered in pericardium. So this is the pericardium. Peri means surrounding, cardium means heart. So actually when you dissect the heart, right, when you will be in anatomy, when you will be dissecting the heart will be looking exactly like this package, right? We won't be able to see any chambers, no vessels. We have to actually cut it, and when we open it, so then the heart will be inside. This pericardium, this entire layer, that merges with this one very important layer. We know that, okay, over here the diaphragm is there, right? In diaphragm, in the anatomy of abdomen, so when we see the diaphragm like this, so in centrally, there is a tendon. Its name is also like central tendon. Right? It is called as the central tendon of diaphragm. So this central tendon of diaphragm, it goes like in continuation with this pericardium. So that's the reason that when the diaphragm moves up or down, it is the heart also which moves up and down. Pericardium, which is divided into two parts. Same exactly like our pleura. But over here, the heart is like, because it is beating constantly, right? So we need to reduce the friction. So over here, the outermost layer, it is fibrous. It is pretty tough, right? Pretty tough. This is the outside layer. And the inside one, that is called as the serous pericardium. So now we have got pericardium, fibrous pericardium, and the serous pericardium. And in between, and in this serous pericardium, it is again divided to exactly like pleura, parietal pericardium and the visceral pericardium. And when we say the fluid gets collected, right, so that fluid is over here. So there would be a small amount of fluid, the same way that we were having that pleural fluid, right, which was between visceral and the parietal pleura. Same way, there is pericardial sac, which is between parietal pericardium and the visceral pericardium. So when we'll be telling that there is pericardial effusion, right, when we'll be using the word pericardial effusion. And in pericardial effusion, we just saw about in last sessions that heart becomes globular, right? Heart becomes like globular, like this. It has to be, because when there is more fluid, then fluid will take that shape, right? So that's why heart becomes globular. Right? Remember the word globular. We'll be watching several such radiographs as we'll be discussing this condition in particular, pericardial effusion. So pericardium is present to prevent the friction, and it also prevents it keeps a check on the heart. That heart should not overfill. Overfill means that when there is hypertension, when there is blood pressure, so it should not. Pericardial sac is pericardial cavity. That's right. Pericardial sac or pericardial cavity, also known as pericardial cavity. You're right. Pericardial sac is a fluid. So right, this is a fluid. So normally fluid is less, but when there is more fluid, then we call it pericardial fluid effusion. Same way like pleural effusion. Right? Same thing. When it will come to say peritoneum, so it will be like peritonitis. Right? So when it will come in abdomen. Okay, so coming back to this pericardial effusion, so this is when the heart becomes like a globular heart. And for the function, one function, so that is very clear, it prevents friction. And it prevents friction. And the second thing, that it prevents overfilling. So you can say such a good protection is given to the heart, but still when the heart enlarges, that is still when you find that there is cardiomegaly, that means something is seriously wrong. That's why it can really go to that level. So this is like central tendon of diaphragm. Okay. Now as we remove the diaphragm, this is how the heart would really look like once you remove the diaphragm. The heart is fully covered with some amount of fat, and this is called as the epicardial fat. Epicardial fat. When you will be doing the abdominal dissection, right, you will find that there will be so much of fat. When you will be doing surgery, you find that yes, there is so much of fat. Some amount of fat, it is normal. It has to be there because there are several advantages. Of very good advantages, it acts as an insulator, right, for the temperature control. But when this fat increases, right, when it is said that when the tummy comes out, right, when the tummy comes out, so then this tummy, it is out. You can imagine that how much fat must be inside, and that fat is called as the visceral fat. Visceral fat. These are the fats which we normally don't see. There would be this epicardial fat as it increases. So obviously, don't we feel like that it would be putting extra load on the heart? Yes, this is the visceral fat. Right? So visceral fat is that fat which we normally don't see. What we see is we see this subcutaneous fat, but this subcutaneous fat, it comes in the last. Before that, visceral fat, it keeps on getting accumulated. So in many of the body scanners, you will find that there is a specific column which is called as the visceral fat. Visceral fat. Everyone measures body fat, but the most important criteria is the visceral fat. If visceral fat is more, so it means your every organ has to work under that much pressure. So due to belly fat, the load on heart increases. Well, due to belly fat, right? Now you are right in two ways. One, which is very obvious. If the belly fat is more, do you remember? We said that there would be dyspnea due to extreme obesity. Right? Dyspnea due to extreme obesity. And that is quite logical also. So this is the body, this is the diaphragm, right? Heart is sitting over here, lungs are sitting over there. Now when the diaphragm is there, diaphragm has to move down and up. He has to move down. But if there is so much of belly fat, right, there is so much of pressure. So then with that big tummy, the whole thing would be pushed up, right? So person wouldn't be able to breathe properly. That's why it is said that those patients, right, those patients who are extremely obese, for them, it would be very difficult to do any of the exercise due to restricted movement of the diaphragm. Restricted movement of the diaphragm. And restricted movement of the diaphragm, that means lungs won't be expanding, they won't be able to move so much for the gaseous exchange. Second, it would be the extra pressure on the heart. Heart has to beat, right? Heart has to beat. Now, if there is pressure from below, then heart won't be getting sufficient space. This is one reason. Second reason, what you said is that due to belly fat, the load on the heart increases. One, This is what we talked about. Second, when the belly fat increases, there would be increase in the visceral fat, and then there would be increase in this epicardial fat also. This epicardial fat is like a constant pressure on the heart. It's like as if you are running and then there is extra weight which has been put on your shoulders. Then you'll feel so uncomfortable. Heart still will keep on beating in spite of that discomfort. But yes, that is the extra load. It decreases the efficiency. Right? So that's how you are writing 2 ways. So we remove the fat. Now we see all the chambers. So this is how the heart would really look like. Now this is the anterior, right? Absolute anterior. This part. This is the right side. So this portion, right? See how wonderfully we see. This is the inferior vena cava. Fine. This one would be superior vena cava. So this one would be the right atrium. In front, can belly fat lead to heart attack? Well, belly fat, it is like yes or no. If the belly fat is too much, then obviously it is like the person might be having atherosclerosis. Right? Atherosclerosis, that means these are the blood vessels, and these blood vessels, they are narrowed down because of the extreme fat. So yes, if it is happening to coronary vessels, it would lead to myocardial infarction. But not only heart, same thing can happen in brain also. So when it leads to brain, then it will lead to stroke, right? Cerebral stroke. Person will be having palsy, paralysis. When it goes into any of the other chambers, say for example, if it goes to the liver, and then the problem in the liver, when there is deposits of fat, then we call it fatty liver, right? Fatty liver. Fatty liver grade 1, right? Reversible. Fatty liver grade 2, difficult to reverse but possible. Fatty liver 3, almost irreversible. Fatty liver level 4, cirrhosis of liver, right? Cirrhosis of liver. So then it is like all the way towards the death. Why heart cells don't divide? 2 reasons. One, we'll see that thing in embryology, that these are very specific cells. These are very specific cells. Right? These cells, once they are differentiated, their entire structure is very different from rest of the cells of the body. And second, so the only 2 cells they come, the brain and the heart, right? These 2. So embryologically, these cells, they are once differentiated, so they will be over there. Now cells, they do divide, but dead cells, once dead, they will never come back. Right? They will never come back. So that's the reason that all the musculature, say for example, biceps. Right? The example of biceps. So even your biceps, whether it becomes you go to gym and your biceps, they become big, and you don't go to gym and it will be reduced to this much. So is the biceps, number of cells are increasing? No, they never increase. They remain same, but they hypertrophy. They hypertrophy. They become bigger, right? So same thing happens even in case of heart. Same thing happens in every muscle of us. So in exercise physiology, we'll see that when it comes to biceps, we have got the, say, fast twitch fibers and the slow twitch fibers. Same thing happens even in case of lung. So same thing happens in case of, say, legs, not lungs, legs. So when you run, so those muscles, they will be fast twitching fiber when it is spread. When it is a marathon, it is a slow twitch fiber. But when you are going uphill, then fast twitch will come into picture, because they can take the load. Right? So thus it is a combination of both. This is the reason that when it comes to marathon, in some of the practices, it is like, say for example, tempo run. तो tempo run, it is like you fix the music and duck, 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 duck. मतलब same pace, but you are going like a machine, right? On some days, it is like HIIT. There is a hill, right? There is a bridge. Over here, we have got a bridge, that ISRO bridge, right? So you go high speed up and then you keep walking. And then take a U-turn, again high speed run, and then start walking. So this is like HIIT, high intensity interval training. So that's how you train all different type of muscles. In myocardial infarction, if the cell is dying, there is no possibility that we could save it. The only possibility is before the cell dies, you save it. That's the reason the initial time frame is very crucial. But once the cell is dead, so then that thing will remain like an infarcted area. Infarcted area means damaged area. You'll be able to see result of this thing even in every ECG for rest of his life. So when we'll be learning ECG, not initially, but say once we have understood all the conditions and time mechanism properly, then we'll see that how to detect the old infarct, old myocardial infarct. And you'll be surprised that how easy, how crisply, because it is manifested so cleanly on the ECG that within seconds you'll be able to say that this is a patient of old infarct, right? Old myocardial infarction. Person has survived, but yes, it happened to him or her. So brain and heart need to protect. Well, I won't take the name as you said. You said that your weight is 110 kilogram, and then there was and there were few other also in the range of about 120 kilogram. For all such 4 or 5 friends, right? When you say that your weight is over 100, there is no jadoo, there is no miracle, there is nothing like jadoo ki chhadi ki yes, it would happen. Just follow this much principle. Just before few minutes also I got that email. This is morning 8 o'clock and this is evening 6 o'clock. Don't make big changes into your lifestyle immediately, but this much is your eating window, right? This much is your eating window. सुबह 8 बजे से शाम के 6 बजे तक. After sunset, don't eat. Must make this one changes. I read your email, right? It was pretty long, and see, if you can't make everyone happy. If your weight is more, then people will say accordingly. If your weight is less, ask those who have said that I want to increase the weight. So for them, the trouble is different. So don't worry about it. Yeah, this is like intermittent fasting, but still better is, I would not say this is intermittent fasting. This is like you are consuming the food only when your metabolism is at its peak. Otherwise, I could have said, na, कि ठीक है, चलो 10 बजे से रात को 8 बजे तक खाओ. No, I'm strongly against it. I'm strongly against it. Sunset, mouth shut, खत्म, कुछ नहीं खाना. Then you have मस्त इतनी बढ़िया herbal tea, green tea, यार पियो, right? At the most, अगर जो नहीं रहा जाता, and you feel like नहीं बस, तो then have apple, बस, nothing more. Then you must have felt good, right? If you are following this. No. The thing is, if this is the area of infarct, right? First, कहाँ से लाओगे यार मसल? इसके लिए जो damaged muscle है, from where will we get it? Right? So that's why, because entire heart works as a single unit. You must have seen that the entire heart contracts like this, right? Whole thing contracts like this. So that's why pura heart transplant, if it is done, then the whole heart is transplanted. Right time to check weight. Right time to check weight is, see, दुनिया में इतने सारे weighing scale हैं, and at times it happens कि किसी ने घर पे weigh किया, and they say कि अरे my weight is 72 kilogram, right? Gym गए, 2-3 दिन 4 दिन के बाद, अरे इतनी practice की तो भी मेरा weight तो 73 है, because there is a difference between those weighing scales. None of the weighing scales are, they are like military accuracy. वो 1-2 किलो इधर उधर होता रहता है. So this will give you a bad judgment. Also, the best thing to weigh yourself is in the morning after you return from the washroom, right? You weigh yourself. Right? Bas. And same weighing scale every time. Bas. Till the bedtime फिर से भूख लगनी शुरू हो जाती है. हाँ, so that will happen. That's why I'm telling you. It happens sometimes when I work till late night. So bindas, I have that green tea, तरह की tea. Say from Amazon, it was some 800 रुपए का पैक था. 10 तरह की अलग-अलग तरह की green tea. Right? All nice green teas. मतलब रोज अलग-अलग बनाओ. And green tea is like water. Right? So it won't disturb your digestive system. Cold infarction affect the function of the heart. Cold infarction is cold. Infarction means lack of blood supply. So we're trying to tell something else. Okay. So this is anterior, so that's why this chamber is right ventricle, and a small portion what we are watching over here is the left ventricle. This is the left ventricle which is projecting, and this pointed out thing is called as the apex, right? And when you'll see if someone is not very much say fatty, so then you'll be able to see that the intervertebral, that is intercostal space, right, over here, right, the skin will be coming up and down. So that is what is called as the apex beat. Even small portion of the heart is affected. Definitely, it will affect the function of the heart. Stem cell works, so many things have been done, but still nothing, no positive results. Right? They claim so many things, but you must have seen that once someone has suffered from heart attack, then none of those things they really work. Okay, we'll come to that. So here it is the right ventricle. From right ventricle, what goes out? From right ventricle goes out the pulmonary trunk. So here it is, the pulmonary trunk. You know? So that's the pulmonary trunk. And this pulmonary trunk will be divided into right and left pulmonary arteries, right? Not shown over here. Now this left ventricle, internally, can apex be called a part of left ventricle? It is a part of ventricle. Right? Apex is part of LV only, left ventricle only. It is a part of left ventricle. So that left ventricle, when we'll see from the left side, it is huge, big one. And there goes, this is the aorta. And this upward going is called as the ascending aorta. Right? It is called as the ascending aorta. Then this thing takes turn. So that is called as the arch of aorta. Right? And from this arch of aorta, and then what goes behind, that would be the descending aorta. Right? We'll see that. And these are the major vessels which will be going towards the head and neck. Right? We'll see that. And this is superior vena cava, which is formed by this subclavian, so right and left subclavian. Why is the heart tilted to left and not straight? No, it is not tilted. Heart is straight only. Only thing, left ventricle, because of its function. Its main function is to push the blood to the entire body. That's why left ventricle has become bigger. So that, as such, the heart is straight only, right? But with slightly projection towards the left side. Okay. So here it is, just one more view, right? So this outer one, which is called as the fibrous pericardium, right? Then this one and this one. This is parietal, and this one which is connected with the heart, it is the visceral, and jointly we call that serous pericardium. Okay? So that's how it forms. Same image. Now all those grooves, they are very important. So here what we have done is we are watching it slightly from the left side. Right? So this one is the right ventricle, and this is our apex, correct? This is the apex. So that means this one would be our left ventricle. So there is why we experience a sudden pain when we take a deep breath. No, there should not be any pain. When you take a deep breath, there should not be any pain. Serous pericardium. This is heart. Very close to heart, almost merged with the heart, is the visceral pericardium. Then comes parietal pericardium. इसके अंदर fluid, and then the whole thing is covered with fibrous pericardium. Right? ये दोनों को jointly we call it serous pericardium. Got it? Now it should be clear. See over here. Okay, na? Right. Fibrous is full bag. Right? Visceral near the viscera. Viscera means organ. Parietal next to it. In between fluid. Right? In between fluid. And this whole thing is serous pericardium. And fibrous so bahar ka cover. Right? Tough cover. So left ventricle, right ventricle. In between the ventricle, there is one groove. This groove. Right? ये तो बाहर से groove दिख रहा है. As such, अंदर there will be full wall, full wall. Right? Left ventricle, right ventricle. So what you are watching over here, this one, it is this portion. It is this portion, and this is the most portion of the heart. It is what is called as the IVS, interventricular septum, or interventricular wall, a wall which is between two ventricles, left and right. And when we draw it in 3D, right, we draw it like this, so that anterior 2/3, who will tell me this anterior 2/3 of interventricular septum is supplied by one of the very important artery, and that is good. You answered quite quickly. Just one answer. 2. हाँ, कोरोनरी तो ठीक है दोस्त, पर ये तो बता, मतलब which coronary artery? Which coronary artery? हाँ, not the left coronary arteries. Okay, right? See, the left coronary artery was like this. Then there was one going like this, and then one which was going like this. Correct? This was left coronary artery. This was called as left circumflex, and then there was one knee. Many of them were right one nahi yaar. Left anterior descending. Left anterior descending. LED, that's right. LED. And this area is vital. Plus, this artery also supplies big portion of the left ventricle, and that's why midowmaker, right? बोलना अच्छा नहीं लगता, but yes, that is like it. So this area is so important, right? This one I just use a dotted one. Okay. This apex, this is into 5th intercostal space. Intercostal space. Let's see the apex point. This was the image which we saw. Right? Yeah, That's right. This is right atrium, inferior vena cava, superior vena cava, right? And then this one is the right ventricle. Left ventricle and everything will be on the opposite side. This what you are watching, this vessel is right coronary artery, right? It is right coronary artery. So when we say right coronary artery, it passes through what? We said that it passes through anterior atrioventricular groove. Now it makes complete sense. It is passing through atrioventricular groove, and because this is right side, right? So right side is anterior. Left atrioventricular will be much posterior because left atrium itself is pitna piche, right? And the right and left ventricle is also quite behind. So our standard figure, if we go by the size, right? So then it could be something like this. It would be something like this. Yes. So this is that groove. This is that groove because this would be the, sorry, my mistake. This one would be the groove. So right atrium, right ventricle, and that's why this one would be called as the anterior atrioventricular groove. The place for right coronary artery. This one is our left ventricle, this one is our left atrium, and the groove between both of them, this one, this obviously it is posterior, right? And this groove, this one is the groove what we were talking about, interventricular septum, which is present over there. Similarly, then it is also called as the interventricular groove, and it is in that interventricular groove what we were watching over here. It is the left anterior descending, that will be passing. And then it will be giving branches to, these are the muscular branches. Then there will be the muscular branches. Oh, this is not LED. LED should be here. But these are the muscular branches. LED is over here. It is still, now you can watch it if I remove this. Right? These vessels which you are watching, that is LED. And this one would be the right coronary artery. And same right coronary artery, it is seen better over here. Yeah, now it is clear. We talked about that as it goes down, right? As it goes down. So this is the right atrium, this one is the right ventricle. And when we watch it from below, so that they go towards, this one is posterior descending artery. Posterior descending artery. So in this case, this posterior descending artery is emerging from right coronary artery. So that's why this would be called as the right dominance. Yada? Right dominance. (85% of the cases. Good. Good. Right? That is 85% of the cases. Dominance, baat ki thi dost. Very quickly we take it. This is aorta, this is right coronary artery, this is left coronary artery, got one branch, left circumflex, and this is the left anterior descending. Then this right coronary artery at the base, right, it gives one more branch which supplies to the base of the heart, and this is called as the posterior descending artery. Right? That is the posterior descending artery. When this posterior descending artery is arising from right coronary artery, it is called as the right dominance. Right dominance. And in most of the cases, that is in 85% of the cases, sometimes it emerges from this. So then it will be calling it left dominance. Right? Left dominance. And sometimes it emerges from both. right? आधी यहाँ से आधा यहाँ से. So that is what is called as the codominance. Codominance. Just go through the last time's PDF. This is explained in bit more detail. This is what you see. Okay, I'll write it over here. This is what you are watching is the diaphragmatic surface. It is called as the diaphragmatic surface. So this posterior descending artery, as if you are watching from below, the area which is resting on the diaphragm. This is as we rotate the heart. Right? As we rotate the heart, you will be able to see. In this case, very nicely what is seen is both the right coronary artery, this is left coronary artery, this is left anterior descending, and this one which is going behind it is the left circumflex. Left anterior descending, right coronary artery, this one is left coronary artery, and this which is going below is the posterior descending artery. Yes, in cardiology we'll be learning a full complete coronary angiography, right? With normal, abnormal, all of them. Okay, so here it is. This one is our right ventricle. This one is our left ventricle, and from left ventricle there emerges this aorta, right? So now we are watching. So this one would be the ascending aorta. This one would be the arch of aorta, and this one is the descending aorta. So things, they go something like this. Aorta is main. Right? This aorta is main. So the three major branches which occur. Right? These are the major branches. One is what is called as the brachiocephalic trunk, right? Which is on the right hand side. This is on the right side. So it is called as the brachiocephalic trunk. Right? A very simple name. Brachio means arm. So this artery, this trunk will be supplying the arm. Cephalic means head. So it will be supplying arm as well as head. Yes, because it divides into two parts. One, and then second goes up. Okay. So this one, that becomes subclavian, and it is this subclavian as it will proceed, right, and it will become axillary and keep on supplying to all the muscles of our arm. This one which will be going up, that is the common carotid artery, a main one, common carotid artery. This is right. We need to say right common carotid artery and the right subclavian, because left common carotid artery goes directly. So this one would be the left common carotid artery. Similarly, directly the left subclavian artery will be, right? So this is subclavian, which will be supplying the upper limb, and this common carotid which will be supplying head and neck. All these things, they go from. That's why this aorta. So this is the ascending. This one is the arch, and then comes the all the way descending. Now this is into the thorax. Right? It's into the thorax, and at diaphragm, right, it pierces the diaphragm, and then it goes into the abdomen, and then we'll be calling it abdominal aorta. Till this point, it will be called as the thoracic aorta. Right? So that's why aorta will be like a huge topic. It will be a huge topic. So from every portion, something is associated. So here is one more view, right? And very, very easily you can appreciate these are. This is one. This will be right brachiocephalic. This will be the left common carotid, and this one will be the left subclavian. Right? This one would be, they will be forming superior vena cava. This one will be the right, this one will be the left, right infravena cava, rest all. Over here, we can see, because we are watching it from the side, right? We are watching it from the side. So here it is, even a small portion of left atrium is seen. It is called as appendage. Left atrial appendage. Appendage means a blind sac or blind pouch. So what does that mean? This is a chamber. In this chamber, if there is something like this, so this is called as the appendage. This is called as appendage. Something which is out pouch. So blood goes, right? But it is just an out pouch. It is not going anywhere further. So this appendage is like that. Much better clarity. As we are rotating. Okay, here it is. As we see, this one is the aorta, and this one is our right ventricle. That's our pulmonary trunk, right? And this pulmonary trunk would divide into right and left. It is this. That is what is called as the ductus arteriosus. Ductus arteriosus. Just a small clarification. In fetal life, right? In fetal life, before birth, this ductus arteriosus is open, right? Is open. So we won't be telling it patent ductus. Patent means something which has remained open, right? Important. Patent means what? Patent means it has remained open. It should have closed, but it has remained open. So when we say PDA, patent ductus arteriosus, that means it is an abnormality. It is an abnormality of someone who has taken birth. But someone who has not taken birth, still in the fluid, still into those first 9 months. So in that case, we'll be calling it ductus arteriosus, because for that particular gentleman or that girl, this ductus arteriosus is normal, right? So that, because lungs are not functioning. Lungs are over here. Lungs are not functioning. So that's why whatever the blood which has escaped into the right ventricle, it will go back. Right? It will be going back into the aorta, and that's how the blood will be used. Will it be much larger in fetal life? No, it is of this size only. Right? It is this size only. It is only this much small. Right? This much small. It is very small. So even in real life, if you really see it, it is pretty small. Because what it has to do, it has to send only that small amount of blood which has escaped. See, these are the lungs. Right? I'm just drawing one side of the lung. This is pulmonary trunk. Pulmonary trunk. These lungs, though, they are not functioning. So there is no point in sending the blood to it. So the blood which is going all the way into the right atrium, right? Over here there is a hole. That is called as, what is the name of it? What is the name of that gap which is into the interatrial septum, right? Because this is left atrium. So this septum is interatrial septum. So there is a hole. Very good. Very good. It is called as the foramen ovale. Right? Foramen ovale. So due to that, the blood, large amount of blood will be pushed into the left atrium. From left atrium, it will go to left ventricle. From left ventricle, it will go to aorta, and it will be supplying that blood to the entire body. Life is good. But what if some blood has trickled down into the right ventricle, and from right ventricle, it made an attempt to go into the pulmonary trunk, but the pressure is so high. because lungs, they are soaked into water, into the fluid, amniotic fluid. So there is no way they can breathe. So why to waste this blood? So for that purpose, this channel is there. And this is the ductus arteriosus. The chances are you might have asked this question, is it that small? Because over here, when explaining, I drew it this big, right? But this was just for the understanding. So as such, they both are so close. So whatever the blood which has escaped, it will go into this. So this ductus arteriosus is normal. But post-birth, when the lungs, blood is going into the lungs, this should close. If it is not closing, then and then we call it patent or PDA. And this PDA is not normal, it is abnormal. It is abnormal. It will be coming under congenital heart defects. So that is what we'll discuss as we'll proceed. So this is the difference between both of them. I remember someone asked this question that this PDA and DA, they are same. Now you know the difference. Okay. Let's open the heart. When we open it, we have opened the right atrium. So all we have done is we have just removed the wall, superficial wall that we have removed, so that we can see that what is inside. The best thing which is seen is this portion, right? This is what we were talking about. This is foramen ovale, but it is not a foramen. In the healthy heart, this foramen would be closed. But band bhi ho gaya, fir bhi this would be the nishani that once upon a time there was foramen ovale over here. But now because that is closed, so it is now called as the fossa ovalis. Fossa means there is a gap, depression. So that is what is called as the fossa ovalis. And this fossa ovalis tells us that this particular chamber, this particular wall, this entire wall, that wall is nothing but it is between two atria. So that's why it is called as the interatrial septum. Interatrial septum. So what if there is a hole in this wall? In this wall, if there is a hole, so that means the blood would be pushed. Which side the pressure is more? Left side pressure is more, right? The blood will be pushed from left side to right side, correct? So over here, this is the left atrium, this is the right atrium. Left atrium has got more pressure, so blood will be pushed on this side. This is the first class oxygenated, acha bhala, best blood, right? Now that is pushed into right atrium. Right atrium to right ventricle to, it will go to lungs. Lungs gali bolega, right? Oxygen wala blood aaya, right? What's the use? So over here, what would happen? The growth of this baby would be shunted. It will be slowed down. It will be stunted. From left atrium, it will go to left ventricle. From left ventricle, it will go to aorta. But the amount of blood which should reach to the body via aorta, that would decrease, right? Because acha good blood is getting wasted. It is going to right atrium. Right atrium is bichara low pressure. He won't speak anything. He will say, okay, let it pass on to the right ventricle. So the amount of blood which will be received by the aorta and then aorta to the body, right, which is growing, which is requiring large amount of oxygen, that oxygen is devoid. So that's why this baby will be weak, right? Every growth will be much slower. So this is just one importance. So here is interatrial septum, fossa ovalis, you know that. Second, what we need to know is this one, right? This one. And that is 1. Because this one over here, it is the right ventricle. This one is right ventricle. This is the right ventricle, right? See the beauty of right ventricle. Kitna powerful muscles, right? See, these are the muscles. See the meshwork of muscles, right? These muscles. And against that, look at the sharafat of right atrium. When we say right atrium is a low pressure system, it looks like as a vicharam, right? So simple, right? Just jara se muscle which are called as the trabeculi. Right? These are all pectinate muscles. You see that. But these are just thode some muscles. Those muscles gently they just push the blood and it goes to right ventricle. The right ventricle is as such the boss, right? Because it has to push the blood into the lungs. So see the muscles. See the amount of muscles which are over here and over here. But when you'll see that left ventricle, so you'll feel like left ventricle to iska bhi baap, right? He is a sumo, right? It makes sense because left ventricle is handling such powerful pressure. So here it is. This is our inferior vena cava, and this one is the valve, right? This is the valve for inferior vena cava. One more interesting thing which is present over here, not see, it is see. This is the place of coronary sinus, right? So this is the valve of inferior vena cava and coronary sinus. And what was coronary sinus? Coronary sinus was a place where everyone was putting their blood, right? That means all the coronary veins, they were dumping their blood into the coronary sinus, right? And that's how it was being. So these were the all coronary veins. So coronary veins, they drain their blood into coronary sinus, which opens at the root of the inferior vena cava, and then it goes into the circulation, right? From right atrium, and then straight away it goes into the right ventricle, and it goes. Obviously, coronary veins, they will be having carbon dioxide, right? Because heart has used that blood. So how wonderful, right? From aorta, as soon as from the root of aorta, right? See over here, from the root of aorta, ekdam fresh, first class oxygenated blood. Before rest of the body gets, it tells that first you have the food, right? So food is ready. So the heart is given the food first by those coronary arteries. And similarly, once all those khali plates, right, they are given to coronary sinus, and it is straight away put into right atrium, and wahan se it goes to the lungs. So that's how the whole heart really works. Moving further, look at the valve, right? Yes, very right. What you said is, you said semilunar. So this valve, this is the valve which is present between the right atrium, and on the opposite side, this is right ventricle, this is the right atrium. So this valve is a tricuspid valve. Tricuspid valve. Tricuspid. So these are the valves. These are the cusps, right? Cusps. And on the back side, you have left atrium. And yes, now you know that they are the pulmonary veins. And this one is the aorta, right? I'm writing again and again so that picture becomes very clear. This is inferior vena cava, this is superior vena cava, correct? And then this one is the pulmonary artery. Which side? It will come on this side. So that's why this one will be the right pulmonary artery. Left pulmonary artery is this one, left pulmonary artery. So this is when we go still posterior. Now we are still posteriorly, and see this. They are the pulmonary veins. Correct. So this means what we are trying to open. We have opened left atrium. Right. It is the left atrium which is in target. And the valve which we are watching over here, this is our most beloved valve, mitral valve, right? It's strong focus. And this valve is a bicuspid valve. Bicuspid valve. So this valve, when we'll see it like this, bicuspid valve. What is this? Just to check whether you are properly oriented or not. What is this? फटाफट यार, जल्दी जल्दी बताओ। अरे आंसर यार, what is this? हाँ, so 3 or 4 answers they come. This is Supe Vinakawa, this one would be Ife Vinakawa, फटाफट यार। पल्मोनरी ट्रंक क्या क्या बोली है, कहाँ है पल्मोनरी ट्रंक? पल्मोनरी ट्रंक, दोस्त, this one, this ये भी नहीं, this one with the pulmonary trunk, ना, है ना? That one would be the pulmonary trunk, and that's how this is 1 and this is 2, right? It is getting divided. And बहादुर, लेफ्ट कोरोनरी आर्टरी कहाँ है? If this size is of left coronary artery, तो बस मजे हो जाए। हाँ, then it is okay. हाँ, क्यों नहीं यार, as many times as you see. Any query, ask. Still previous? Okay. Because it is the clarity. Once this picture is clear ना, फिर देखना ECG में क्या मजा आता है. You'll be able to actually visualize so many things. So here it is, our next one. This is interventricular septum. So here we have got right ventricle, and here we have got left ventricle. See the thickness of the muscle of this, and see the thickness of the muscle of this. This is interventricular septum. And यहाँ से, right, this portion what you are watching, right, this shiny part, it is that shiny part which is the, क्योंकि इसके जस्ट पीछे क्या होगा, इससे पीछे there will be the left atrium, so that one is the mitral valve, this one is the mitral valve, and this one is the tricuspid valve. So in other words, we are watching tricuspid valve now from the other side, right? Previously we were watching it from the right atrial side. So here, see, this is how we are. This is so that mitral valve, right? Here, in fact, which here it is. Here it is, right? This is the right atrium, and we are watching tricuspid valve from the right atrial side, and then we'll watch it from this opposite side, right? So to be from this side, let's see. Here it is, right? Now it is clear. Right? So this is the right atrium. This is the right ventricle, left ventricle, tricuspid valve, mitral valve, and the interventricular septum. Now the cusps in mitral valve, as we said, there are 2 cusps, right? So there is anterior cusp and the posterior cusp. Cusp means like the cup shape, right? So they are called as the cusp. And in case of tricuspid, one would be the septal, right? So same way like this is anterior, one is anterior, second is posterior, and third one, which is near the septa, it is called as the septal. Septal. This is one of the very good image where we can actually see that how these muscles they really, I mean these valves, how they really work. Well, we are watching towards the tricuspid valve. So clearly, one cusp, second cusp, the third cusp. So these are the cusps. What we have to see and understand is, can you see this? Associated with it, these are the muscles. So let's start with muscles first. These are the muscles. They are called as the papillary muscles. Papillary muscles. Once you'll understand this whole process, then you'll feel like that creation of this itself is so amazing. So these are the muscles. So when this muscle contract, what will happen? It will pull the cusp down, correct? So this is the papillary muscle part. The whole thought process will start from this papillary muscle one. This part, for time being, just forget. Then here is another papillary muscle, right? So that one is also a papillary muscle. So that papillary muscle would control this septal cusp. Okay? So these are the cusp. And there is another muscle which is present over here, right? That papillary muscle. So I'll just put the arrow over here. These papillary muscles, they are connected with a cord-like structure. So these papillary muscles, they can contract, right? But these cord-like structures, they cannot contract. These are like strings, right? Very powerful strings. So they are called as chorda tendini. They are chorda tendini. And then the valves. Till this point, everything looks good. But then there is someone over here, a thick one, this one. And who is talking to everyone, right? Say it is connected to everyone. This is what is called as the moderator band. Moderator band. छतरी कई बार उल्टी हो जाती है, right? This moderator band will control everything in such a way that it should not be going reverse. And second, right? One, it controls papillaries. And second, very important thing, that all the muscles, they should contract at the same time. It should not open one cusp has opened, then दूसरा आराम से खुल रहा है, third तो is still waiting. No. So it supplies the impulse. So that SA node to AV node to bundle of phase to Purkinje fibers, those last fibers, they will be coming via moderator band, and then moderator band will be the control center, will supply all the three, right? As the impulse comes, it fires to three together. So all the three papillary muscles, they contract and the whole valve opens, right? So it carries impulse to all, impulse forward. So that's why it is called as the moderator band. Very important. Right? So if anything goes wrong to moderator band, so then this synchronicity, it goes away. Just a good image. Right? So just it is for the revision. Because everything is seen is finely. So here we have got the right coronary artery, right? Then this one is the posterior descending artery. Then this one is the left anterior descending. Then these are the muscular branches. Right? These are the muscular branches. All good. Cindy, see? This is on this side. So we have got this is right ventricle, this is left ventricle. This is right ventricle, this is left ventricle, this is left anterior descending. Right? LAD, and then all those branches, muscular branches. Well, they are also called as the marginal branch. In case, right, they are also called as the marginal branch. Marginal branch. And then there would be one branch which will be down. That is what is called as the septal branch, which will be giving anterior 2/3 of the intervertebral septum. What's the first point? Which one was there? What we're talking about? This one. This is like the beginning, right? The entire thing starts with this papillary muscles. Things start with that papillary muscles, and then it pulls the chorda tendineae, and then that chorda tendineae will pull the whole one. Okay. Moderator band control. If the LED isn't forming PDA, then where does it end? Well, it just divides and it ends up giving the muscular branches. The idea is PDA is that who will be supplying to the diaphragmatic surface of the heart, right? Who will be supplying to the diaphragmatic surface? So that is what is happening. That is what is coming via PDA. So that's why PDA in most of the cases it is by RCA or it is by this LED. But whosoever is giving, so finally to all these branches, right, they will divide, and they will end up in giving the branches to the muscles. Done. And this one is the left circumflex. See how it winds around, it goes posterior. Orientation, if you can figure out, you should be from the structure, right? From the structure itself. These two on both the sides, right? Then over here, so here we are talking about base, right? This is the base of the heart. So what we are watching over here is this is PDA, posterior descending artery, and these are all the branches. They are the inferior branches. Inferior branches. This is just the base. See the power, how these muscles, they really look like. Same image. Now this is a complete section taken, right? As if we have taken the whole section. This is just for one purpose. See, when we take a section, right? Watch this. These are the fibrous ring. These are the fibrous. This is the fibrous rings. And these are the rings which are giving support to the heart. Right? So it is not so that heart is just because imagine if there are only muscles, if there are no bones, then whole body will crumple. Right? It is because of the muscles, because of the bones, it is standing. So this is the infrastructure, right? It is the basic structure of the heart, and on that the muscles are mounted. So these are the fibrous rings. These are the fibrous rings which are around aorta, which are around this tricuspid valves. Right? You will find all these fibrous rings. So these fibrous rings, they give support. See, you can see it over here, right? All these things. So here it is. See how nicely you can see this is one cusp, this is the second cusp, and this one is the third cusp. 3 cusps. So this means this one would be a tricuspid valve, right? This one is a tricuspid valve. Against that, a big cusp, one, and another cusp over here, right? So this one is the mitral valve. Mitral valve. but whichever valve it is. Right? Similarly, over here, this one would be the aortic ring. So these are the fibrous rings which are present deep inside, so that they give power and strength to the entire structure. This we are interested in. At the root of the right atrium, here lies the. So this is now no problem in identification of the chambers. So that is the right atrium. At the root of the right atrium, that is at the base of the superior vena cava, here comes the SA node, sinoatrial node. The junction where there is superior vena cava and atria are there. That is the SA node, sinoatrial node. And then over here, that one is the AV node, right? At the junction of atria and ventricle. So this one is the AV node. So here is the communication between SA node and AV node. This SA node is on the right side, so there would be going one branch which will be going to the left atrium. Right? So right now we are not drawing it not to make it complicated, but we can just do it like this: that this is the SA node, right, and this is the AV node. One branch, it goes to left atrium. Because over here, from here, it will be directly going into the right atrium. And here starts the journey for the AV node. So now you know that this AV node, it is the only window between upper heart and the lower heart. So that's the only window. So none of the signal would be leaking from here or here, no, nothing. Right? It has to pass through this AV node, and it is this AV node which generates delay. Right? Generates delay. And it generates delay. Why should it generate delay? Why not to let immediately the pulse go? Right? Why there has to be delay? What is the reason of this? Reason? Why the delay? It sets the pace. Okay. 1, 2, 3. 3 correct answers. 2 incorrect answers. 3 incorrect answers. 4, 5 correct answers. See, to set the pace, right atrium and left atrium filling. Are you sure? Is for the right atrium and left atrium filling? अरे भाई एक बात सुनो. From here the right atrium and from here the left atrium. AV node won't come into picture. AV node won't come into picture for the right atrium and left atrium contraction. Am I clear? See, yahan pe this is one bulb, this is another bulb, here is a fan. If anything goes wrong to this, will it affect this bulb and this bulb? No. So logically, it has to be something. Iske baad, what happens? Okay, don't worry. Right? See, when the current comes to right atrium and left atrium contract, when they contract, they don't relax. For relaxation, no signal is needed. They will relax. Right? When the current goes, they contract. They contract means blood is pushed. Blood is pushed from those valves, right? Mitral valve and the tricuspid valve. So, ऐसा थोड़ा है कि मतलब this blood it goes like a fraction. It is a physical movement. So that blood when it is pushed, so all those who have answered for ventricular filling, right? That is in fact the perfect answer. To fill the blood, right, into ventricles or to relax the ventricles. Ventricles relax. We can say that, but the perfect answer would be to allow ventricular filling, right? To allow time for to allow time for ventricular filling. Okay? And when the ventricles are filled, fire, right? Then this thing comes into picture. This is the bundle of His. So here it is the bundle of His. His is a name, right? So there is nothing like bundle of her. And then it goes all the way in the form of Purkinje fibers. How do the signals given to left atrium? There is one specific branch which goes. Okay? Yes, a specific branch. There is one branch which goes to the left atrium. So that's why right atrium and left atrium, they both contract at the same time. Still, when you go at a deeper level, you will find that right atrium is so near, na, ekdam paas mein hai. Left atrium to thoda dur hai. So that's why there is a small delay generated even in this also. That right atrium, though it is near, but it takes few microseconds extra, so that right and left, they both contract together. Otherwise, see, if the mitral and the tricuspid valve, they are not getting close together, so then what would happen? We'll be getting split first heart sound. First heart sound, lub, that occurs when the valves close, right? But see the precision. Mitral and tricuspid, they both close at the same time. So there is no difference, right? We just hear one sound. There are two doors. Whenever the doors they shut, there is sound. When the doors open, there is never a sound, right? So when the doors shut, so they both shut at the same time. When they open, no sound. When they shut, same sound. But what happens if it goes like this? Right? This is like first heart sound, but it is called a split heart sound. Split because one is closing faster, second is closing slower. So whenever someone tells split first heart sound, it means mitral and tricuspid, they are not getting close together. When it comes to split second heart sound, the split second heart sound is formed by aortic and pulmonary valves. So again, though aorta is under so much of pressure, pulmonary is under less pressure, but both the valves, they close together, right? But they are soft. So that's why these valves, they are big valves. Lub, and the second heart sound, da, right? Lub, da, lub, da. So it is like, right? First is sharp, right? Vibrant. Second is very diffuse sound. So that's where when you will say that when there is one method which is one heart sound which is called as galloping, as if ghode daud. So this is where the heart sounds are getting split, right? So that's how you will. I'll show you all these. I'll make you hear all these auscultations. But listening is of no use unless you understand that this is happening. Every time I'll say, whenever you auscultate, close your eyes, right? Think ki kya ho raha hai, right? See, this is first heart sound, first second. Because from the quality of sound, first second. Because everything is happening so fast. When the person's heart rate is 72, that means within 0.8 seconds, everything is happening. First heart sound, second heart sound, sab aa raha hai. But yes, first and second will come fast. First, second. So that's what you have to understand. First, second. Right. So in timeline, first, second. First, itna to gap nahi hoti, just understanding. First, second. Right. So that's how you'll decipher. And then when you hear like, right, when it goes like two things are happening, so that's where you identify this is split first heart sound or split second heart sound. Split second heart sound, it is very difficult to identify because as such it is so diffuse. So that's where you'll rotate and you'll use the bell of the diaphragm, bell of the chest piece. Right? In stethoscope, this big one is called as the diaphragm. Right? And this one is called as the bell. So when you want to hear such subtle sounds, very delicate, so then you will use bell. And bell is to be applied very delicately to the chest. Right? While this diaphragm, it has to be hold like. but it has to be held like this, right? Your diaphragm, you'll be holding it like this, and then you apply, and then you hear. But when it comes to belt, you'll be holding the stethoscope with its neck. This is the neck. And delicately you'll put it on chest, and then you'll start hearing all these delicate sounds. So these are then Purkinje fibers, and these Purkinje fibers, then they distribute to all these muscles, right? So that they don't only give to muscles, but they also give to all these papillary muscles, right? Via the moderator bands. Just in slightly more detail. So that's how the whole network really goes. See here, right? So these are the moderator bands, and via moderator bands, it will be supplying to these papillary muscles. Just a beginning, right? This is P wave, Q wave, R wave, S wave, and the T wave. P wave is when the right atrial, not right, but just the atrial depolarization. So when we say atrial depolarization, that means when there is spike, right? When there is spike, when there is current. When there is current, that means this is the time when the atria would contract. So that's the P wave. See the QRS, so big, because over here, this is the phase for ventricular depolarization. Ventricular depolarization. So big wave, right? Big muscle. So that's why it is this PR segment. PR segment is what? PR segment is that when SA node has fired, and this is the point when the AV node will fire. SA node has fired over here. This is the SA node. This is the AV node which has fired. So it is this PR segment which is actually the filling segment. This is the time when the ventricles are getting filled. Ventricular filling phase. Correct? And then the ventricles contract. And when they contract, when the current goes, yes, this is the wave which is happening. And then the ventricular repolarization. When the ventricles they relax. Right? So where is atrial repolarization? Well, atrial repolarization, it gets submerged into ventricular depolarization, because the wave of this atrial repolarization is very low voltage. So atrial repolarization, it gets merged here, right? It gets merged in this big wave only. So this was just the beginning of the ECG. We'll see. Patent foramen over there, some representation. This is actually like this is PDA, patent ductus arteriosus. So like a cross section, how it really looks like. Just to show the musculature, right? That how powerful. And yeah, one more thing. The cross section, which shows that this is the aorta, right? This is our left ventricle, and that's the aorta. See how the aorta goes. Right? Aorta and pulmonary trunk. PQRS complex, here it is. Ajahn. Pulmonary trunk and aorta, interestingly, so they both emerge from a common tube. Right? There is a common tube, and then there would be a formation of septum in between, and then the whole thing would rotate, and both the tubes, they will become separate. Right? In embryology, we'll see that. So they will become separate. Once they are separate, so then they will start functioning accordingly. But sometimes if the septum is not developed, then we will find the overlapping. Say for example, in tetralogy of Fallot, right? Tetra means four things are there. But the first thing is there is hypoplasia of pulmonary trunk. That means pulmonary trunk is very thin and aorta is this big thing, right? Pulmonary trunk is so thin. Same thing, no? This is one tube. When the septum develops, we both get 50-50%. But what if the septum develops something like this? So this is the small pulmonary trunk and the big aorta. And that is the reason that aorta overrides in such a way that half of the aorta is into the right ventricle, half of the aorta is into the left ventricle. Right? So that's where the mixed blood comes. We'll see that thing. But that's the point which I wanted to explain, that pulmonary trunk and the aorta, they both merge from a common tube. And then there is a septum in between develops. And then it rotates. So this is why this very interesting situation, that when it goes like this, right? The trunk goes like this, right? The trunk goes like this, and then it goes. This was just a graphical representation, but quite similar to real one. This is myocardial infarction. As you are watching this image, two things can happen. Either there is no signal, or it can lead to some errors in the signal transmission. So either there won't be any signal, or it can lead to some errors, which is called as the round and round, right? The reverberating signals, they keep on rotating, and unnecessary they keep creating the various types of tachycardia. Just the thickness of the muscles, all various sections. Right. So that was for today. Thank you so much. And keep writing and take care. See you soon. Oh yes, happy Navratri to all of you. Thank you. Happy weekend also. Tomorrow there is a big race, 42. Okay, see you. Bye-bye.